Good morning, everybody. My name is Professor Roger O'Sullivan, and on behalf of the Institute of Public Health, I'm delighted to welcome you here today. The theme of this event is physical activity and frailty. It's not often you hear those words in the same sentence, but they should be. And over the next 2 hours, you will hear about the role of physical activity in preventing, delaying, or reversing frailty. Frailty is a common and serious syndrome that affects many older adults. But the good news is that physical activity can play a crucial role in combating it. A recent paper found that 1 in 5 adults aged 50 plus on the island of Ireland are frail, and about 1/3 of those aged 50 plus on the island were identified as pre-frail. Today, we will explore how regular exercise and movement can help maintain strength, improve balance, enhance well-being, leading to a more healthy and independent later life, and improve overall quality of life. The goal as we age is to retain our physical and cognitive function and delay the onset of illnesses and disability. One of the key challenges facing public health is that physical activity levels tend to decrease as we grow older. But it doesn't need to be that way. We need to challenge that assumption among others and ourselves. The evidence is clear. Physical activity can play a crucial role for our health and well-being at every stage of our life, including later life. The often overlooked fact needs to be emphasized and reframed. Maybe we can think of physical activity as our fountain of youth. I'm struck that the theme of this webinar has really struck a chord with so many people. We have 1,000 plus people registered for the event today. We have people from across different disciplines, different occupations, different sectors and geographies, including people from across the island of Ireland, north and south, as well as England, Scotland, Wales, Spain, Luxembourg, Belgium, Italy, Slovakia, and Mexico. So thank you very much. The format of today is there will be 3 presentations. Our first speaker is Professor Maria Fiatarone Singh from the University of Sydney. Maria, thank you so much. It's now after 7 p.m., so thank you for the dedication. Our second speaker will be Dr. John Travers, GP and lecturer at Trinity College Dublin. Our third speaker will be Alison Patterson from the Frailty Network, who works at the Public Health Agency. Thomas McCabe from Sleeve Blue will help us to get moving with a few energizers over the course of the morning. Given we're talking about physical activity, let's just not all sit for the next 2 hours. And following that, then we'll have a panel discussion. Leila Beatty, Dr. Ruth McCullough from UCC, George Bell from the Frailty Network, and Roman Romero Artuno, geriatrician at St. James's Hospital and professor at Trinity College Dublin. To help make this event as interactive as possible, can I ask you to please submit your questions for the panel in the Q&A function within Zoom at the bottom of the screen, and my colleague Toby Finch will group these together and pass them to me, and I will ask the panelists. If you want, you can use the chat function also at the bottom of the screen to share your area of interest, any insights that you're getting on or observations with the rest of the people that are online this morning. And I really hope you get a chance to maybe tweet out using the hashtag active aging. And I hope that this event will be enjoyable, informative, active, interactive. If you want to learn more about the work of IPH on physical activity, check out our website, sign up to our newsletter, and try out our free learning pathway on physical activity that's available from the Google or App Store. So now we're going to move over to our first speaker, Maria. Maria Fiatarone Singh is a professor of exercise and sports science at the University of Sydney. She's also a senior research associate at Harvard Institute of Aging, and she's also the director of the Center for Strong Medicine. I had to read this twice, Maria, because 450 peer-reviewed publications and over 85 million Australian dollars in research funding achieved. Wow, thank you. Thank you. And for those people, this is a great privilege to hear about your work. And if you get a chance, Maria has a range of our lectures on YouTube. They're really worth watching. There was a great one with one of our friends was going to do the Cadota walk. I watched the interview with the 85-year-old gentleman. It's most certainly a challenging walk. So over to you, Maria, and thank you very much.
Thank you. It's really a pleasure to be invited to participate in this webinar. I am a geriatrician. I've spent the last 36 years or so looking at the effects of exercise for the prevention and treatment of frailty and lots of other chronic conditions. So I'll talk a little bit about the rationale, what I think works, what doesn't work, and how we might think about implementing this in our clinical and research practice. So obviously, frailty is very complex. Physical fitness and physical activity is one component of the prevention and treatment, but many other things also matter, including nutrition, psychological well-being, and purpose in life. So today I'm going to focus on physical fitness, knowing that it's just part of the overall story. So where does exercise really fit in? If you think about it, it has a lot to do with the attainment of our peak physiological and genetic potential. In addition, thinking about risk factors for the prevention of frailty and chronic disease, as well as diseases that are imminently important in the onset of frailty, treatment of pre-frailty, and frailty itself, as well as the many comorbidities. So I think the problem that I see clinically is really that a lot of what is done in practice is probably just lip service to the idea of medicine. I think we really need to do a lot better to think about how we might use exercise as medicine more centrally in our practice. So you can use exercise to prevent or treat diseases, to substitute for less effective or more hazardous forms of treatment, perhaps to augment the effect of other effective treatments, offset the side effects of current treatments, and counter age-related changes in physiology, which are risk factors for morbidity. So if you think about the first part in terms of optimizing peak body composition, this is where really exercise comes to the fore. We don't have drugs that do any of these things in terms of reaching our peak physiological potential. So this is why we need to think about preventing frailty even in children. The next area, which is really the prevention of risk factors for chronic disease, again, exercise is really the primary way that we can do this. We do have one drug available that can prevent risk factors for chronic disease, which is metformin for the prevention of diabetes, but that's really it. So again, exercise really needs to be thought of as quite central. Once we get to the treatment of diseases, obviously we have many, many drugs that are available and effective, but for almost every chronic disease that we can think about, exercise has an augmenting role and perhaps can lessen the amount of drugs that we use for these conditions. And there are some things for which we really don't have drugs, particularly things like falls and frailty itself. And when we get to age-related changes in physiology and function, again, it's very much like the beginning of life. Exercise is quite important for all of these areas. We do have drugs that work on things like metabolic dysfunction, osteoporosis, but not sarcopenia. And although we have drugs for obesity now, there are negative side effects to those drugs, in particular the loss of lean tissue, which might exacerbate the sarcopenia and osteoporosis that's already occurring. So again, exercise really needs to be thought about as quite central. And frailty, we have many definitions of frailty, but probably the one that I think is most closely related to exercise and its potential is Linda Fried's frailty phenotype, which I've turned into S's here for ease of remembering. But all of these factors of frailty have something to do with exercise, as we'll see. And we really have no safe or effective drugs for aging itself, for frailty, or many of the risk factors for frailty. that you see on the screen here, and even dementia, for which we do now have some drugs, those drugs actually don't have very large effects, and in fact are probably not as effective as some of the other kinds of interventions that we can use, including exercise. So in terms of the rationale for exercise, I think the most important point is that there are dose response and modality specific relationships between exercise and frailty. Robust exercise is really where I've focused most of my work over the years. And this refers to the appropriate modality, volume, intensity for a particular health condition. And just as there are dose response effects with medication, this is really what we see with exercise when we use it as medicine. Unfortunately, there is a bit of resistance to robust exercise. Some of that, I think, comes from ageism, fears. A lot of it comes, in my experience, from myths perpetrated by healthcare professionals, particularly cardiologists, I might say, misinterpretation of published data, inadequate equipment in unsupervised settings for people who are quite frail. So there is a lot of issue that we need to resolve if we're going to actually incorporate exercise more centrally in our prescriptions. And the most important thing I think that we've learned over the years is that really, if you think about exercise adaptation, it is quite specific. And if you want a specific physiological outcome to occur, it's not good enough to just prescribe exercise without thinking about the modality or the intensity. Many years ago, this is what I said in my very first lecture at Harvard, that frailty is not a contraindication to robust exercise, but rather one of the most important reasons to prescribe it. Nothing has changed. I had no data to prove that at the time, but now we have lots of data that really shows that, in fact, exercise really needs to be done in a very robust way for frail individuals. And guidelines such as the Asia-Pacific guidelines are very clear now that we need to think about exercise as key to the management of frailty. And in fact, the kind of exercise that is most central is anabolic exercise, strength training, resistance training, at least as one component. In addition, thinking about polypharmacy and nutrition, where it is part of the syndrome, is very important. So most of my work has focused on resistance training, and we'll think about each of these Linda Fried's components of frailty in regards to exercise. So shrinkage or loss of weight or lean body mass is really quite central. And what we know from longitudinal studies is that even in people who are weight stable, they're losing lean tissue with aging, and it's only people who actually gain weight who don't lose lean tissue, as we see in this slide here. So weight stability itself actually masks this lean tissue loss that we see with aging. Why are people losing weight? Many causes, obviously, and so frailty treatment is not just about exercise. It's also about thinking about some of the components that might cause malnutrition as part of the scenario. So very much important to think about the other allied health professionals in terms of diagnosing and treating causes of malnutrition. As you get older, the provision of a nutrient-dense diet, which is diverse, becomes more and more important because energy intake is usually lower because of the loss of lean tissue. Vitamin D deficiency becomes quite important. And weightlifting exercise is actually anabolic, meaning that it increases appetite. It also increases nitrogen retention from the gut. So even if you're not eating more protein, you will absorb more nitrogen if you're actually lifting weights compared to being sedentary. And if you pair up weightlifting exercise with extra nutrition, you can actually improve dietary intake, which is not the case if you just prescribe nutrition by itself. So that's a very important way of adding to the benefits of weightlifting exercise, is thinking about adding protein in people who are actually undernourished or protein deficient when you start. Slowness is another very central component of frailty. If you ask a child what a frail person looks like, they will walk like this. And we know now from a large number of studies that you can improve walking in older adults, depending on what the cause of the slow gait is. Different kinds of exercise might be needed, balance training or aerobic training, or perhaps simply strength training if muscle weakness is one of the components of the slow gait speed. So we see this in the systematic review, an improvement from PRT alone with no other kind of exercise in people who have slow gait. And in the LIFE study, which is probably the largest exercise study in this cohort and to date, there is a benefit for multimodal exercise. 28% reduction in major mobility disability, which was most significant in people who actually had a low SPPB score to begin with. You can see that it actually didn't have a significant benefit in people who were quite fit. And the exercise that was done in the LIFE trial was really mostly walking, a little bit of balance, not really much weightlifting at all. And I think the frailer you are, probably the more important it is to add more of an anabolic exercise component to the exercise regimen that you use. And in this study, the exercise actually didn't work in people who had MCI or dementia. Most of it was unsupervised. And we see this from other studies that if we have cognitive impairment as part of the scenario, then unsupervised exercise tends to have a very modest effect on outcomes. Strength loss is obviously key to frailty. And this is where exercise really has probably its most potent effect because of the body composition changes of aging that we know about, in which there is visceralization and centralization of adipose tissue, loss of muscle, loss of bone, and very significant losses in muscle, 40, 50% losses over the lifespan, particularly in the type 2 fibers, the fast twitch fibers, as you can see in one of my nursing home biopsies here. And this shift in body composition with excess fat and decreased muscle not only has implications for frailty, but also for all of the chronic diseases, particularly the cardiometabolic diseases that we think about, but also things like depression and dementia. All of them have links to this shift in body composition with aging. So it becomes very critical to try and prevent it. And how do we prevent it? Well, we know actually from epidemiological studies that aerobic exercise, as seen in this study by ClickGuard here, does not prevent the loss of muscle mass with aging, whereas recreational weightlifters actually have very similar muscle characteristics to young, healthy men. So the modality of exercise becomes very critical in this body composition alteration with aging. So when we first started looking at the data that was out there, we figured that weightlifting exercise was probably the thing that was missing from the frail elderly individuals in the nursing home studies that we use. And we didn't know what to do. So we actually did exactly the way that you train healthy young individuals, training them with high intensity weightlifting exercise. And we saw that the loss of lean tissue was related to their strength and their muscle composition. And we could improve it very, very easily, 100% or more in just 10 weeks with very typical weightlifting exercise. The control group got the gentle exercise paradigm that is very rampant even today among frail elders, tossing around a beach ball, waving the arms around. That does not work for anything. In fact, that is the control group, not only of this study, but of every randomized controlled trial that we've done since that time. So we know very well that it doesn't work for physical function, but it also doesn't work for psychological function. The multinutrient supplement was important for increasing muscle size in the people who were undernourished in this study. And we saw for the first time in adult humans, not only hyperplasia, but also not only hypertrophy, but also hyperplasia, new muscle cells, new myoblasts being formed in the skeletal muscle of these people in their 10th decade of life. So the eccentric damage of weightlifting, although it is damaging acutely, ends up causing an adaptation which is beneficial to the person in terms of extra muscle hypertrophy and strength gain. And we saw this in the people getting the combination of the weightlifting and the exercise supplement. So in research studies, it's easy to show. In clinical practice, probably may seem a little bit far-fetched that we could see this. So here's an example of one of our patients, Sylvia, a litany of diseases, as you can see on the screen here. She's not a successful ager in the Harvard terminology. She's aged with lots and lots of chronic diseases. Luckily, she ran into my PhD student, Nathan, 12 years ago, has been exercising, lifting weights since that time. And in that period of time, over 11 years, she actually didn't lose any muscle mass or strength at all. She gained a lot of strength other than the COVID shutdown, which you can see here, in which she lost a lot of her muscle strength in a very short period of time. But as soon as the clinic reopened after COVID, she was able to gain back that strength. And her lean body mass, not that typical loss of lean body mass that you would expect in somebody at this age, but actually a stability of body composition over 11 years of aging. So it is possible to change the trajectory of aging. It's not common, it's not usual, but I think that's because we're not using the right kind of medicine, in fact, to address it. So treating both sarcopenia and obesity is really what's necessary. In the focus in medicine clearly has been on obesity, pharmacologically and in diet. But I think we need to think about a very different approach to body composition if we want to optimize health and frailty. Sedentariness is another component of frailty. And we know that even if you don't tell people to exercise more, once you give them back strength and balance that they're missing, in fact, they will spontaneously walk a bit more around their environment, whether it's in a nursing home as shown here or in the community. So the idea that you can actually take people who are very frail, very weak with poor balance and just tell them to walk more or encourage them to walk more, I think is the wrong approach, because if they don't have the physiological capacity to walk safely, in fact, the studies show that they will fall and fracture more if all you do is tell people to walk who don't have the strength to do it. So I think we need to take a step back, start with the physiological abnormality that they have, and then add the right components of exercise. And the final component is sleepiness or fatigue. Lots and lots of reasons, obviously, in people who are frail that they might have this component. Some of the things are addressable by exercise, some of them by medications, some of them by social support, but all of them are important in terms of preventing insomnia, which we now recognize as a risk factor for not only disability, but also for things like dementia. Depression is one of the causes of insomnia, and we know that exercise, both weightlifting and aerobic exercise, has a very potent effect on depression, 2 or 3 times larger than the effect of medications and a lot safer, in fact. Physiological conditions and physical symptoms and diseases which can cause insomnia. Again, a litany of diseases, and you can see on this list, some of them are things that exercise can also help, like arthritis, like COPD, like CHF, like rotator cuff tears. So again, thinking about treating sleep, not just by giving an insomniac or even giving CBT, but looking at the underlying causes and figuring out which of them you can actually improve with things like physical activity. So what works for frailty? Well, the Asia-Pacific guidelines clearly state that resistance training is a core component. Unfortunately, most of the trials in frail older adults have not really used robust evidence-based exercise to try and impact frailty. Most of them have used things that are probably a little bit low in terms of intensity. And we do know that intensity matters in terms of exercise adaptations, particularly for strength, but also for frailty itself. And very closely aligned with intensity is progression, because if you're not progressing the load as you train people, then it will become less and less intense over time. So these 2 components of the prescription are actually the most vital in my experience in terms of trying to get people to adapt robustly. And how you progress is important. If you measure people's strength, they have very potent changes in strength compared to if you just guess or subjectively ask how heavy the load is. And even if you're looking at something like gait speed, if you're measuring strength and progressing it over time, they get much larger benefits for gait speed than people who are just progressed in other ways. So doing it the way that people do it in athletes is really what's most important for doing it in people who are frail. There are meta-analyses comparing high versus low intensity weightlifting and high versus moderate intensity in older adults, very clearly showing that the benefits are greater with the higher intensities. So we would never give a suboptimal dose of a drug if we knew that a higher dose worked better. But for some reason in clinical practice, low suboptimal doses of exercise are very often what, in fact, people prescribe. So these are the training elements that we know are optimal for PRT adaptation, higher intensity, resting frequency 2 or 3 times a week, a very modest kind of volume. These are the things that actually work. And it's not rocket science. It's not different than how you would train a 20-year-old. But in fact, it's the least common way that we see people, in my experience, trained in the community. There are studies now showing that if you compare moderate to low intensity exercise for things like actual change in ADLs in older adults, that moderate intensity is better than low. But again, looking at these kinds of studies, there are very few, if any, studies of high intensity exercise. So I think we need to do a much better job generating the research that will then disseminate, hopefully, into clinical practice. And when you look at some of the comorbidities of frailty, like cognitive impairment, again, it turns out that dose actually matters. This is our study of high-intensity weightlifting exercise for people with MCI, showing that resistance training was very significantly better, gained the most strength, had the best cognitive outcomes. So it's not because being stronger makes you smarter, but it's because something anabolic that causes robust adaptations in muscle also causes robust adaptations in neurons. What that factor is, we don't really know yet, whether it's IGF-1 or BDNF or something else, but it does seem to be going in the same direction. And nicely enough, not only does the muscle grow, but the brain grows in size when you do weightlifting exercise in this area of the brain called the posterior cingulate cortex. We saw that the changes in the brain volume were related to the benefits in cognition over the 6 months of exercise. And we followed these people for 18 months. It turned out that the hippocampal volume was also either attenuated in terms of its atrophy or actually increasing in size 18 months after the exercise started. So very long-term changes in the brain, very significant clinical improvements in cognition with this very simple kind of exercise, which I really feel needs to be central to the treatment of cognitive impairment. Similarly, with depression, you can show that aerobic exercise works, weightlifting exercise works. But again, we see this very clear dose response effect where low intensity weightlifting actually has the same benefit as a placebo. So if you want to use it like a drug, you actually have to pay attention to the dose response characteristics, whether you're talking about depression or cognition, or in this case, hip fracture. This is our study of hip fracture, looking at weightlifting exercise and other treatments of frailty in these individuals. And we saw an 85% reduction in death or nursing home admission in the 12 months after hip fracture in people who got this treatment compared to usual care being physiotherapy and usual GP care, but not involving the high intensity weightlifting exercise and the other components of frailty being treated. So very, very important for the most morbidly afflicted individuals, including those who have hip fracture. And this benefit continued for 2 years, even though we had stopped the intervention at 1 year. So a very significant benefit clinically. So I think in summary, the principles of evidence-based exercise for the prevention and treatment of frailty, in my experience and ability, are more often barriers than attitude. The need for anabolism increases with age and frailty. Prevention of frailty and its risk factors is linked to both aerobic and resistance exercise, and higher levels and higher intensity of physical activity are important. But once you get frail, then you have to prioritize the modalities of exercise according to the specific determinants of frailty. Sometimes you need balance training in addition to resistance training. I think you always need resistance training. And if people can do it, you can add aerobic training later. But that sequence is probably most important. There is this linear or curvilinear adaptation, which is still there even in the last decades of life. People do not stop responding to exercise, even in their 90s. And frailty is therefore not a contraindication. We also know from the literature what doesn't work. So there's some large studies such as STRIDE, for example, looking at falls and function, using very low intensity, I would say minimally progressive exercise, as you see here, completely ineffective for the prevention of falls. The Do Health study, you may also know, probably the largest study that will ever be done, looking at frailty and other outcomes, again, completely ineffective for all of the benefits you see on this slide. And if you look at the kind of exercise they did, it was very much like the controlled gentle exercise classes that we use in all of our randomized controlled trials, because we know they're not effective. I think we need to do better than this. People need to have robust exercise, just like they have evidence-based medications, if we want to benefit them. So we know from the literature, these are all the things that do not work for physical or cognitive frailty. And these are things that are the control groups of randomized controlled trials, but they're also the things that, at least in Australia, are the typical geriatric senior exercise class. So don't waste people's time. They don't have long to live, maybe only 10 years. So do something effective if you're going to treat them, and go to the literature to find out what works. So what's next? Well, I think we're trying to implement exercise in various settings, in dialysis units, in hospitals, in nursing homes. I don't have time to show you the videos, but happy to share them later via the platform. I think what we need to do is actually figure out how to deliver robust exercise, whether it's in the home setting, as in our home care study, or whether it's in clinical settings, because we know what works, we're just not actually using it. And optimized exercise and nutrition, this needs to start in utero and continue throughout life. The older people get, the more they need an anabolic form of exercise to outweigh the catabolic and inflammatory influences on life. And so that means that the type of exercise you prescribe tends to go from aerobic as you're young, aerobic and strength training in middle age, and focusing more on PRT and balance and gait training as you get to very old age. But that changes over the course of the lifespan. So the key lifestyle principles, I'll end with this, I think, are to maintain high energy expenditures throughout life, recognize that anabolic exercise need increases throughout life to mitigate these body composition changes that are so critical for disease and disability. We need to match energy intake to energy requirements, which means nutrient density has to increase, as well as protein and micronutrients. Maximize a dietary diversity, plant-rich diet, Mediterranean-ish type of diet is probably the healthiest for aging. Accumulate anti-inflammatory exercise, lifestyle, and dietary habits. Practice the lifelong learning of novel things, and don't do it alone. And if you'll recognize the Mediterranean diet pyramid, the bottom of it is actually socialization, eating in company, growing your own food. So it's not really just about the nutrients that you're putting in your mouth. It's really about how you get them and how you eat them in company of others. So I think all of that becomes quite important for frailty. So is it possible? This is my clinical practice in Sydney, the Center for Strong Medicine. These are some of my patients. My office is over on the side here. It's very small compared to the room that we have for the exercise equipment. This could be the way geriatric offices look in the future around the world. I'd say many of them probably don't at the moment. But this is, if you're really serious about geriatric medicine, you really can't leave exercise out of the equation. And so we have to figure out how to change how we deliver healthcare in order to deliver what is really evidence-based and so critical for our older patients. So thank you very much.
Maria, thank you for a marvelous presentation. I really enjoyed that. Really excellent. And there's loads of comments in the chat. Okay, so we've talked about the benefit of physical activity and exercise. And before I was really impressed by some of those weights that people are lifting there, Maria. That's really, really impressive. But Thomas, I don't know if you're going to get us to do that level of weightlifting today, but we're now going to move over to Thomas McCabe from Slave Blue, and he's going to help us get a little bit energized, given we've just been sitting for about 25 minutes or so. So over to you, Thomas. Thank you.
Brilliant. Thank you, Roger. And Maria, thank you for a fantastic presentation. Unfortunately, we don't have the level of weights that you had to hand today, but I'm going to take you through a quick energizer session. So I'm Thomas McCabe. I'm the National Manager of CL Ireland. We're a social enterprise that delivers tailored exercise programs for Ireland's older adults, people living with various chronic conditions, including stroke, Parkinson's, dementia, COPD, and also for people living with mental health difficulties. We deliver our services in 20 counties in the Republic of Ireland in person and also via our online platform. So I'm going to take you through a number of energizer sessions today. So we'll go through a quick one right now of moderate intensity, and we'll have a higher intensity session later on in the webinar. Okay. So I want you sitting up nice and tall, hands on the knees. Okay, head up and back straight. Okay, we're just going to warm up the neck muscles and work our way down to the body. So once you look it up as high as you can and down. So 1, 2, 3, 4, 5, and 6. And we look over the right shoulder as far as we can. And over the left. So 2, 3, 4, 5, and 6. Excellent stuff. We'll take the chin down to the chest and just roll the head around. So 1, 2, and 3, and back the opposite way. 1, 2, and 3. And next thing we'll do, we'll raise the shoulders up and down. Okay, up and down. Almost like someone asks you who's going to win the US presidential election. You can make the face too if you want to. 5, 6. We're going to go for 20. 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, excellent stuff. Okay, next thing we're gonna go for right shoulder up, left shoulder down. So 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Super stuff so far. Okay, so the next thing I want you to do is, okay, hands together, out like so, almost like we're hugging an invisible tree. Bum stays in the chair. We're going to twist around to the right as far as we can, and around to the left. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Excellent stuff so far. Hands down by the sides. The bum stays in the chair. We're reaching down to the right as far as we can. Get a nice stretch down the opposite side and down to the left. So imagine there's a 20 euro note on the floor to your right and a 50 to your left. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. And next thing, we're just going to tap the toes. The next thing, we're in the toes up and the heels up. Toes up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We'll mark the legs. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Okay, hands out in front. Okay, palms facing outwards, elbows nice and high. We're pulling the elbow, pulling the chest back. Okay, and we're going to squeeze our 2 shoulder blades together. Keep the elbows nice and high. Imagine we're trying to hold a credit card between our shoulder blades and backwards. So back out. Then credit card, elbows nice and high. So 2, 3, 4, 5, 6, 7, 8, 9, and 10. Excellent stuff. Let's make 2 fists and we'll open our toes to hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Excellent stuff so far. Okay, so that's a quick energizer, folks. That was just around 5 minutes. Okay, thanks very much. And I'll be back to get you warmed up. We'll do something a little bit more intense in the second session. Thank you very much and enjoy the rest of the webinar.
Thanks there, Thomas. Okay, so now we're going to have John. So John's a general practitioner based in Dublin. He's also a senior lecturer in the School of Medicine in Trinity College Dublin. He's a graduate of UCD and Harvard University. And he completed a PhD on building resilience and reversing frailty. So John, thank you so much for giving up your time today. I really appreciate that. Thank you.
Thanks, Roger. Delighted to be here. And thanks to Thomas, feeling wonderfully energized now and ready to go for the second session. And Professor Maria, a fantastic opening presentation. I learned an awful lot. Hopefully some of this will resonate with what you said, but also hopefully some will build a little bit on it. So I'm delighted to have the opportunity to share some of the work that myself and colleagues, including Roman Romero-Ortuno, who we'll hear from later, have done on reversing frailty and building resilience over the last 7 years or so. I believe that every single one of us intuitively understands what frailty means and have done so, in fact, from the beginning of time. I think it's a very human characteristic that all of us understand and with whom it resonates. 2,500 years ago, there was an adage reputedly said by Buddha, in fact, that he said, "See how the frail tree is overturned by the wind." And I think that that metaphor nicely captures the sense of vulnerability of the state of frailty. And there's an Irish poet, Patrick Kavanagh, who I often think about. And his line, "Every older man that I see reminds me of my father." And I think this is a very poignant and quite beautiful and elegant description of the concept of frailty that we all recognize and that we see in the body language of older people, that slightly stooped shoulder, the tentative gait, the sense of vulnerability sometimes in the use of a stick to help to mitigate the risk of falls. And I think, as Maria has mentioned, even a child, when they're asked about frailty, they can take on perhaps the stooped gait of an older person. So it really does resonate with us all. And indeed, frailty, when people on the street are asked what their thoughts are on frailty and their perceptions, and I'm conscious Alison will talk a little bit more about perceptions, but some of the initial feedback is actually quite negative. There are negative connotations, such as this sense of wasting away or an inability to do things, a sense of helplessness, even feeling shriveled and thin. And this is genuinely what people feel when the concept of frailty is presented to them. And that is reflected in things that I've heard in my clinical practice, when an older man, for example, leant in towards me and said, "You know, John, once you're frail, you're frail." This sense of irreversibility. And a lady who said to me, "Frailty feels like a one-way street when you're getting old." This sense of inevitability. But that, for me, was a key part of the start of our research, because despite this sense and this common belief that frailty can be irreversible and inevitable, there's an opportunity there. And myself and colleagues wanted to challenge that perception and ask the question, can in fact frailty be reversed through feasible, very doable interventions with older people, and particularly in primary care where I work? Back briefly to the medical definition of frailty, because although we've understood it intuitively as people, I think, for a very long time, in medicine, it's a relatively new and fertile area of research and area of understanding. And it's described broadly, there are various definitions, but one that I like is this diminished capacity to respond to external stressors. It is very prevalent. There's a study that we looked at recently which described that 12% of all those aged 65 and over are in a state of frailty. And Roger actually mentioned an even higher prevalence earlier, 1 in 5. So there's some slight variance, but at least 12%, and it rises as time goes on to about half of those aged 80 and over. It's been described as the most problematic expression of population aging, and increasingly everyone's business. So I hope to begin with, start to set some context for how frailty resonates with us as individuals and how prevalent it is. It can be really simply screened, and there are various ways to do that. There are some quite quantitative approaches using the phenotype criteria, and Maria talked about Linda Fried's approach of 5 criteria that define frailty. There are other index-based criteria lists, the deficit approach to measuring frailty. This is a somewhat subjective and perhaps judgmental screen, but I think it's so simple and so also quite elegant, and it actually works quite nicely for fast or immediate screening in some ways, where our clinical consultations in primary care or in an emergency department are tight on time. This can help us gauge where a person might sit along the frailty to resilience spectrum. And in primary care, people often present older people in the categories of 2 to 5 or 6. And often those who are in long-term care in nursing homes are in the categories 7, 8, and 9. Why is frailty important? It's important because of the aging demographic to begin with. In Ireland, and it's reflected in a lot of Western democracies, the rate of growth of those aged 65 and older, for which there's a high prevalence of frailty, is 3 times higher than the rate of growth of the total general population. Why is it important? Because a person who is in that state of frailty has a 3 times higher mortality compared to a person who is non-frail. Why is frailty important? Because a person who is frail compared to a person who is non-frail is twice as likely to visit an emergency department in any given year. If they do visit, they're 3 times as likely to be admitted. and will spend 4 times as many nights in hospital. And in primary care where I work, a person who's frail compared to non-frail will visit on 4 more occasions. And that, of course, leads to a higher healthcare cost and resource requirement. And in fact, typically, the marginal cost of frailty is about €10,000 per person per year for a person who's frail compared to non-frail. So again, I've just spent the opening part underlining why frailty is such an important concept in our aging demographics and for all of those key reasons. And now I want to move to the opportunity and to understand, well, what can we do about frailty? How can we intervene? How can we tackle frailty, particularly in primary care? And then to bring it back to our overall theme of exercise and dietary intervention. So myself and colleagues went about this in a very structured way. The first thing we did was we looked at everything that had ever been published on interventions for frailty in primary care. And we looked at almost 1,000 papers, and we analysed 46 in details. And I mapped those on a matrix of what were the most effective interventions compared to which were those that were also easy to implement in terms of time, money, and resources. And to save you looking at these particular studies, I've grouped and looked at patterns for the types of studies that were the most effective and the easiest to implement. And we were encouraged by the fact that the ones that were most effective were also the easiest to implement. And this starts to resonate now with what we've already been hearing about the importance of strength-based exercises paired with nutritional supplements, which is the second half of an effective and easy to implement intervention. And that compares, for example, with the comprehensive geriatric assessment, which is regarded as the gold standard for frailty, which, yes, it is, of course, there are high levels of effectiveness. And however, it's quite a resource intensive approach. It's multidisciplinary. It requires lots of time and energy and invested in the people for whom it's being provided. And yet the simple truth is that a series of strength-based exercises and nutritional supplements across the 46 studies were shown to be the most effective and easiest to implement. And that was backed up with a subsequent meta-analysis that showed the same thing. So myself and colleagues then asked ourselves, well, what if we could build on the shoulders of all of the most effective interventions and co-design a definitive intervention that we could test in an Irish population? And so we looked at the exercises that worked well. We co-designed and refined those with physiotherapists, geriatricians, and 112 older people themselves, most importantly, who were at the heart of the co-design. We did a lot of workshops, discussions, interviews to ask in what format and what type of way would you like these exercises to be shared? Videos versus simple handouts versus group classes versus gym and supervisor-led approach to this. And the strong feedback we went with was to keep it as simple as possible. And we co-designed with the older people a handout of exercises, which will be made available by the Institute, I understand, subsequent to this, with a variety, but majoring on resistance exercises. And as has been pointed out, a push or an encouragement for there to be progression in terms of the numbers of repetitions of exercises over time and in terms of the amount of weight. And I think, in fairness, what's really interesting about what Maria said was how important it is to focus on higher intensity exercises in that hard to very hard category. And I think what's interesting reflecting on these is that they are probably moderate intensity, mild to moderate in fairness, and yet I'm going to go on to show some of the results that were achieved that hopefully builds on some of the other evidence that's already been presented. So there were 11 exercises. This gentleman is holding bottles of milk, 2-litre canisters of milk, because we wanted to make it as accessible and easy for somebody to engage with these exercises. There's no need to go to a gym setting. There's no need to have particularly complex equipment, but weight-bearing exercises using things that are to hand. And I often say to people, drink the milk and fill the bottles with sand or water. And there's a mix again of resistance, but also some balance and gait type exercises. I'll come back to these presently. So the first thing we did with this set of exercises was test it in a feasibility study over about 12 months with another 95 older people. And there was 8 different criteria, all of which were satisfied. And this shows just one, which people said, well, in fact, the exercises were easy and to follow and to do. And they gave some anecdotal feedback, and I'd love to just talk about one or two of these quotes. One person said, my wife and daughter are doing them too. We enjoy doing them as a family, and they get easier the longer you do them. Another person said, I started to do the leg ones and can now walk up my stairs at home. That, for me, is actually profoundly beneficial to a person where previously they weren't able to access the upper level of their home, their bedroom, their private effects, their bathroom, where the exercises that they undertook now has opened up that part of the world to them and helped them to regain a sense of independence and a sense of ownership of their lives and their activities. And that same person went on to say, they stirred me on to do more exercises, and they remind me you can do more than you think you can. And I contrast that with the previous quite negative connotations that were associated with the concept of frailty, where people are now presented and invested in with a simple exercise guide where they are now doing something about this state of frailty and feeling the sense of great empowerment as a result. So the feasibility study, of course, and nice anecdotal quotes are really one level of evidence, but we wanted to get a much more robust evidence around this particular intervention. So we designed a randomized control trial in 6 general practices in Ireland. And we refined the exercise regime with a female model. We took out one exercise and again encouraged this daily routine nudge, if you like. We also then created this protein guidance sheet, because as I said, protein is the second part, and for me, a really key part to turning the work that somebody is doing, that anabolic stress on the muscles and bones. It turns that work into, it provides the building block, I should say, to turn that work into manifest muscle tissue and bone tissue, in fact, as we'll see. And the target protein intake for an older person is 1.2 grams per kilogram of body weight per day. So a 70 kilogram adult taking 84 grams roughly. And this guide enabled people to see roughly, where can I get that protein from? The typical serving sources. So 8 grams of protein from a glass of milk, 6 from an egg, 25 to 30 grams from a piece of fish or chicken, and then a series of plant-based proteins on the whole right side here, which are arguably better for one's health and the environment. And so we're providing people with the information, we're arming them with the information to help them engage in the intervention. In the randomized control trial, we not only measured frailty state and status and progression and so on, but we also wanted to look at muscle mass, muscle quality, bone mass, and biological age. And we used a simple bioimpedance analyzer to record that. Before I go on, I should provide a slight addendum to the protein. For those with chronic kidney disease stages 3 and 4, the 1.2 grams is taper. So again, the importance of having a healthcare professional, a GP nurse, GP practice, or a doctor involved is important. So again, we went on and measured those different parameters. Again, we were encouraged and enthused by some of the results here. Using the phenotypical model, the slightly more quantitative approach to measuring the categories of frailty, and we used the SHARE-FI model, which is part of the phenotypical family of screening methods. And we had people in the categories of non-frail, pre-frail, and frail. And on the left side, we had the intervention group, on the right side, the control group. And those in the group that were frail, in fact, reduced by 2/3 in the intervention group compared to the numbers of people who were frail in the control group after a 3-month period. So 3 months later, people doing the interventions, 2/3 of those who were frail at the start were no longer frail at the end. I should say, averaging out the numbers across the different groups. And you might say, what about the non-frail and the pre-frail groups? Well, we also found a significant reduction in frailty score across all 3 categories in the intervention group compared to the control group. We also found an increase in grip strength in both women and men in the intervention group, those doing the exercises, and a reduction in the control group. And lastly, another slide, which isn't here, measured biological age. We found that those in the control group were 3 months older on average compared to the start of the exercise after a 3-month period. So that makes complete and intuitive sense that they would be, because time has passed. For those in the intervention group, the average biological age was 7 months younger. So that was a 10-month swing. So to Roger's point in his opener about exercise potentially being the fountain of youth, there may well be something there, more than just an aspiration. Now, I have to again add another disclaimer that there was a high effect size in that result, but it wasn't quite significantly significant. With a larger sample group, we had 176 in ours, but with a larger sample group, that may well become significantly or statistically significant, but a nice reflection on the study. So in summary of the particular intervention that we co-designed and trialed, we found that it was a simple, acceptable, easy to do intervention. It improved frailty status, frailty score, grip strength, activity level, slowness, and bone mass significantly. And this is often overlooked. Maria talked about the change in sarcopenia, but I'm delighted to be able to say that this particular study also showed a significant improvement in bone mass after a short period with this moderate intensity exercise program. Frailty was reversed in more than 1 and 8.4 participants. And again, it was feasible to do in primary care consultations. We got quite strong feedback. Now, lastly, I want to just briefly talk about the concept of resilience, which is at the other end of the spectrum to frailty. And this dynamic interaction between somebody who can become less frail can become more resilient. And here, perhaps, is the face of resilience, where there's a gentleman whose house has been swept away in a flood, and yet he has the demeanor of somebody who is very much getting on with the reality of it. In fact, he looks like he's just walked off the set of a Western movie, that chiseled jaw and so on. And it really, I'm just trying to capture that essence of the meaning of resilience, which is the ability to bounce back from difficult, stressful situations, be they physical and or mental. And the crossover between the physical and the mental, I think the glue there are things like the social interaction that Maria's also talked about. So there certainly is a crossover. And here is a 65-year-old woman carrying quite large blocks, rebuilding her home just north of Kiev after her home had been bombed in the last year. Again, an example of somebody sort of advancing through adversity, which again is the definition of resilience. And we've captured a series of very nice stories of that type of resilience in a publication due out soon. So I'm going to pause there, and delighted to take any questions in due course. Hopefully this was a helpful reflection and an overview that, again, resistance-based exercises and the correct amount of protein to supplement that can have a profound influence on a person's quality and length of life, and in particular older people. We're never too old to start these types of exercises. And I hope that you take this away for your own personal lives, but also for that of your loved older people in your lives. Thank you very much.
Thank you, John. That has been fantastic. I really appreciate your presentation. John, there are some questions in the Q&A. If you could answer them directly as we move on into Alison's presentation, that would be much appreciated. So thank you again, John. Now we're going to move on to Alison. Alison is the Frailty Programme Manager for the Public Health Agency. Prior to taking up this post, she had a number of roles in planning and commissioning of services, and Alison's going to present on the Frailty Network and also the Perceptions of Frailty survey that both George and I were involved in developing the framing of that. So looking forward to seeing the results, Alison. Thank you very much for your time today. Really appreciate it.
Thanks very much, Roger, and thanks for the welcome and the introduction. So yes, I'm just going to give a quick run through on the Northern Ireland Frailty Network, what we are basically and what we've been up to, and as Roger said, then move into some of the findings from an omnibus study that we did last year on the perceptions around frailty. So if we could move to the next slide. So the Frailty Network in Northern Ireland was established in 2019, and at the moment we're sitting with over 1,000 members, which is really wonderful. It has grown incrementally. And those people represent over 100 organisations across Northern Ireland, Republic of Ireland and beyond. We're very much a partnership with AJNI, and consultative forum members, including George, who's with us today, play a very active role in our work. And everything we do is based around co-production and co-design. Just a quick plug as well, if anyone would like to join our network, there's the email address. You can just pop us an email, or you can make a note of the website, and there's further information there on how to join. So our work so far, we very much from the early stages, we're keen to focus on education, and Roman and colleagues from Ireland have been very kind and shared with us their Fundamentals of Frailty programme. So we've been working away on tailoring that for use in Northern Ireland, and we're at the stage now of rolling that out in our trusts, with South Eastern Trust being first to take that on board. We've also done an awful lot of work on the public health messaging around frailty, and Roger and George have been heavily involved in that. In terms of identification of frailty, we had a task and finish group looking at, basically coming up with the decision that it was really important across Northern Ireland that we move to identify frailty routinely and the make every contact count philosophy. And the tool of choice for that is the clinical frailty scale, which John has shown us in his presentation. We've been working with Trinity College Dublin, Dominic Trappell, I'm not sure if he's on the call today, to look at the economic modelling around frailty. So basically looking at what the most cost-effective interventions are. And that work very much concluded that there's a very strong evidence base for physical activity, particularly around strength and balance training, and good nutrition, and ideally a combination of both of those things in terms of the prevention of frailty and potential reversal. We're also working on delirium and deconditioning at the moment. It's a new piece of work for us, very much recognition of those harms that often occur, particularly in a hospital journey, and the impact they have on older adults as they are potentially discharged to care settings other than their own homes. We've done a lot of work as well around falls and safer mobility. That work began as part of the COVID response, particularly thinking about the needs of people in care homes, and a new Northern Ireland pathway for fall prevention in care homes has been developed, and that's being rolled out at the moment. We're widening that out now in terms of safer mobility in people's own homes as well, looking across all sectors. And nutrition, I'm really glad to see, has been mentioned quite a lot here today. We've had a lot of recognition of the importance of good nutrition. And the messaging for older people as we age, I think, becomes a little confused. So we're embarking on a piece of work to look at the current messaging around that, and whether we need some new resources which give better and more targeted information to the older audience, particularly thinking about protein intake. We've also been talking to staff, and we know that staff feel they're not overly well informed about nutrition and in a position to maybe give advice on nutritional needs or spot someone who might be at risk of malnutrition. So we've developed an e-learning module for staff, which is also dovetailing into our Fundamentals of Frailty programme. So why is active ageing a priority for us? So we know that frailty syndromes, particularly immobility and falls, are massively impacting older adults, and that's presenting in terms of tiredness, a general slowing down, loss of muscle, loss of strength, and people being at increased risk of falls. Also, the Four Nations Clinical Medical Officer guidelines suggest 150 minutes of vigorous exercise per week is the target for all adults. But we know, talking to older people, that messaging can be very much confusing for them. What does vigorous exercise look like for me? And a lot of people feel, that they're maybe a bit of a failure if they can't keep up with that. So our message is very much all movement is good. Do what you can and try and increase a little as you feel comfortable. And very much that use it or lose it messaging. We also know from the impact of the lockdowns during COVID that we were very concerned about older people who were deconditioning in their own homes due to the lack of their normal routine. And we surveyed our network members, a lot of whom are clinical staff, and they were concerned as well because they were finding people were being referred in, for example, to a fall service at a much younger age than would normally have been expected. And I know, Maria, you referenced that in your presentation as well. Again, our health economist work that's already been mentioned talks about the huge benefits of physical activity in preventing frailty in later life. And I'll talk to you a wee bit shortly about our public opinion survey, but, key information coming from that. Almost a third of people between 50 and 64 who responded to that made no connection between physical inactivity and frailty in later life. So some of the pieces of work that we have done so far, Move with Mary and Keeping Well at Home, these were combined sort of hand in hand and featuring Lady Mary Peters, who, if anyone isn't familiar with her, she's very much a local hero in Northern Ireland and a former Olympic champion. And she very kindly made a series of 5 YouTube videos for us, each demonstrating a warm-up, cool-down, and a range of exercises to suit all needs, both seated and standing. And they were done in safe surroundings and physio-led. And again, like John's programme, they very much encourage people to use household items, maybe a tea towel or a can of food. So great feedback on those. They were widely covered across all media outlets, really well received, and even received a commendation from the late Queen Elizabeth. We also developed a series of Aging Well calendars and issued these over 2 consecutive years, targeting the 65 to 74 age group in the initial year. 140,000 calendars were issued across Northern Ireland, and each month gave a new focus, and there was some sort of key information initially on our Take 5 messaging. I know this is probably quite hard to see on the slides, but I'm happy to share anything further. So we covered things like general safety at home, protection from scams, but also big features on activity, months where we encouraged walking, where we encouraged staying warm in the winter months, nutrition messaging, and some recipes, and they were really well received. 80% of people who received them were very satisfied with the information that the calendar contained and found it very useful. 44% felt they'd learned something new. 36% adapted new habits based on what they'd seen in the calendar, and 28% had actually tried something new. So we repeated this exercise with AgeNI in 2023 and issued a further 50,000 calendars via community pharmacies. So our Living Well campaign then is ran again with community pharmacies across Northern Ireland, and we had a focus on physical activity and ageing well. And that ran for 2 months. This is a programme that we deliver every year in collaboration with Community Pharmacies Northern Ireland, and we have 2-month features, so 6 programmes a year. You can see there that 521 community pharmacies took part in that and targeted over 55,000 customers, and 65,000 leaflets were issued, just some wee images there. And that was basically pharmacies were given signposting material and briefing notes, and were able to identify someone who they thought might benefit from this information. And you'll see some nice, with some lovely stories in terms of feedback. But there we can see an older lady living alone who suffers from mental health issues was advised to take short walk from her home to get fresh air and a little low impact exercise, and later reported back to the pharmacy that she felt the benefits to her mental health and was now able to gradually walk further. I'll not sort of read everything off to you, but maybe another one here that isn't on the slide, where pharmacy staff spoke to an elderly gentleman. He'd been struggling with mobility issues and a sedentary lifestyle. Staff encouraged him to start walking just with a gentle bit of exercise. Initially, he was hesitant, but eventually started walking short distances, and over time his confidence grew and he began walking longer distances. And this simple lifestyle change has improved his cardiovascular health. Now, obviously, taking on board Maria's point about balancing risk, but that was part of the briefing information that pharmacies were given. So moving into the public perceptions information, and as Roger said, himself and George took a very active role in designing this survey. So it was ran across 1,000 people aged 18 and upwards in Northern Ireland. Some of the key sort of findings were there was actually very little difference in how the genders, religions, and the economic backgrounds answered most of the questions. The 50 to 64 age group did display lower levels of awareness around inactivity, protein intake, smoking, alcohol consumption, and isolation and loneliness, and their links to frailty. We'll have a slide on that later. And the younger age groups were less likely to be familiar with the term frailty and sort of what it meant than the older age groups. You'll see there a breakdown of the age of people who participated. So initially, we asked people if they had heard of the term frailty before, and you can see just over 50% of them said that they had. So the rest either hadn't or didn't know about it. And you'll see there, the breakdown in the age groups is more likely to have heard of this term if you're in the 65 plus, age group, much more likely. So we asked respondents, we gave them some statements to agree or disagree with. And we said that frailty is an inevitable part of growing older, and everyone gets frail at the same age. And I suppose interesting to note that the younger age groups were more likely to agree with that statement. And when we looked at the 65 plus, over 60% of them strongly disagreed with that statement. And I don't know about anyone else, but I do see this in the older members of my family. Definitely talking to older adults, frailty is not a term that they connect with. It doesn't describe or define them. And I think I see that sort of determination in my parents to keep doing things that they've been doing for years, and no one's going to tell them. I've made that mistake a few times, that there's something they shouldn't potentially do. And I actually see that rebellious streak starting to form in my father, because just a couple of months ago, I returned home from work to see him on the roof of my house at 80 years of age. So I think I'll just have to keep my mouth closed in future. So we asked people if they were aware or unaware that being active decreases your chances of developing frailty. And you can see there, most people were aware and that's good news. But again, the older age group and the 65 and overs had that increased awareness about that. So obviously, I think it is that sort of when it sort of comes to your door, it's potentially something that you're more familiar with. So again, sort of flipping some of these questions around, asking people if they were aware or unaware that being physically active and maintaining muscle mass can help increase physical and mental well-being in adults. Similar to the last statement, high levels of awareness around that, but with, again, an increased awareness in the 65 plus age group. So this was an interesting one. We'd ask people about the links between some medications and frailty, asking them if they were aware or unaware that some medicines can increase the risk of frailty. And very much we see there that the awareness is quite high in general, but interestingly in the older age group, awareness is lower, and with more people being, sort of unsure or not being aware of that at all. So I think that sort of guides us to something we might need to do to raise awareness about that. We asked people if they believed that frailty would be associated with pain, depression, poor cognition, incontinence, unintentional weight loss, and loss of independence. And the 65 plus age group were less likely to view that statement as being true than the younger age group who responded. So many do sort of seem to see these symptoms as part of aging. So there were a number of questions and statements that were put to respondents where we noticed there were little differences in variation of answers across the age groups. So I'll just sort of cover those quite briefly here. Hearing and visual impairment can increase the risk of frailty. Only 44% of respondents were aware of that, and the rest were unaware or didn't know. And again, I do see that in my own home life, with my father having severe hearing loss and the impact that's having on him. So ask again, when you have frailty, you can have low energy, slow walking speed, poor strength, vulnerability, and increased risk of falls. So good news that 83% of respondents were aware of that fact. Social and economic background can affect the risk of developing frailty. Less than half people are aware of that. So I know we have our health minister in Northern Ireland is very keen to do some of the sort of the work around health inequality. So, I think there's information there that can target that work. Lifestyle factors such as poor diet, smoking, alcohol consumption increases the risk of frailty. So 3/4 of respondents were aware of that, and the remainder either didn't connect with that. Frailty is always irreversible. 17% agreed with that, and the remainder were unsure or completely disagreed with that statement. And being inactive increases your risk of developing frailty. So 3/4 of respondents were aware of that fact. But again, no differences across the age groups. Okay, so just a few more questions that, again, didn't notice differences in the age bands in terms of how people responded. I asked if there was a connection between the risk of frailty and being stressed, lonely, or isolated. 67% were aware of that fact, and the rest were either unaware or didn't know. Being socially connected and having good mental health, 69% of respondents were aware of that, and the rest unaware or didn't know. Your diet with adequate protein and whole foods has a connection between risk of frailty in later life. 70% aware of that, and the remainder unaware or didn't know. And lifestyle factors such as poor diet, smoking, alcohol consumption, again, 74% were aware of that fact, and the remainder didn't know or were unaware. So I think there's some interesting feedback there, but I think that the general messaging, I suppose, is that the younger audience probably tend not to really think about these things. And as we progress through life, it sort of, as I say earlier, when things come to your door, you're definitely more aware of them. So it will guide our work moving forward. And there's definitely that subtle messaging that we need to take on board. So just another plug again for our network. Anyone wishing to join can either email us on that address or they can connect through our website, and we'll take it from there. Thank you very much for your time today.
Thank you, Alison. That was a great presentation. Really, really great. Thank you. Now we're going to move over now to Thomas to do a quick energizer, and then we go into the panel discussion afterwards. So please, if you have questions for the panel is George, Roman, Laila, and Ruth. Please submit the questions in Q&A. And if you have questions for Maria, John, or Alison, you can put them also into the Q&A, and they'll be able to answer them online. So thank you very much. Over to you now, Thomas.
Perfect. Okay, we're just going to raise the intensity here a little bit for a second energizer. Roger was keen that this is going to be a 20-minute energizer, but we'll shorten it because we're a little bit behind time. Okay, so we're just going to start off and we'll march the leg. Okay, march for 30 seconds. Getting that legs up. Okay, let's get the hands out the front. Work that core. And another 10 seconds. Three, two, and 1. Okay, I want you to take the right hand on the left shoulder, left hand on the right shoulder. Elbows up, chin up, back straight. Let's take the elbows down to the knees and back. 1, 2, 3, 4, 5, 6, 7, keep that chin up nice and high. 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Okay, so next thing we're going to move into some squats. Okay, so we're going to keep our feet shoulder apart, toes pointed outwards, hands on our shoulders and hands out like so. Or if you want to grab a chair, go ahead and do so. We're going to come up as high as we can and back down. So 1, 2, very good. You can see a few people getting up and down. 3, 4, 5, 6, 7, 8, 9, 10. We'll go for 10 more. 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Excellent stuff so far. Brilliant. Okay, right hand on the left shoulder again, left hand on the right shoulder, elbows up. We take the right elbow down to its left knee, and left elbow to right. So 1, 2, 3, 4, 5, just 5 more, 6, 7, 8, 9, and 10. Excellent stuff. Let's get some fists up. I'm going to come a little bit closer to the screen. Fists up. Picture someone you don't like, probably me at this moment in time, and you're going to punch straight out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Excellent stuff. Keep them fists up. Okay, instead of punching out, we're going to throw a nice big uppercut now, the knockout blow. So here we go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Excellent stuff so far. Last exercise we're going to do. Okay, we're going to move back just a little bit, and we're going to do 10 more squats just to finish off. So feet shoulder apart, toes pointed outwards, up we come, and back down. So 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Excellent stuff so far. Brilliant stuff. Okay, thank you very much. Well done. And if you want any more information on CL Blood, you can find us on our socials or via our website, clblood.ie, www.clblood.ie. I'll type it into the chat, and enjoy the rest of the webinar. Thank you very much.
Thank you, Thomas. That's been brilliant. That's really got us energized, particularly because if there's little sense of us sitting to hear about physical activity. That's really, really brilliant. Thank you. So we're now going to move into the panel discussion. So Roman, George, Leila, and Ruth are going to come on board and answer some questions. So we'll just do it. Leila, do you want to just tell everybody who you are?
Well, who am I? What am I? I'm a young 78-year-old, and I do quite a bit of exercises with various groups, with senior citizen groups, similar to what, not as energetic as what Thomas was doing there now, chair exercises. And I do some games, and I do some dances, games with the equipment from Age and Opportunity, the sports partnership games. And
Brilliant.
do some dances, the dances are of course to music.
Brilliant. Thank you. That's excellent. So Ruth, you want to just introduce yourself?
Thanks, Roger. I'm Ruth. I'm one of the lecturers in physiotherapy in UCC, and I have a strong interest in older adults and frailty and falls and Parkinson's. And I'm also the lead researcher on a study at the moment looking at a falls prevention programme, an evidence-based falls prevention programme in Ireland. We're trying to scale it out, and there's early sites that are setting it up in Ireland, and we're just trying to learn lessons from these early sites so that we can see how well we can build it up in Ireland and scale it out so that it's so much more accessible for people.
Brilliant. Thank you. Roman.
Hello, good morning, everyone. I'm delighted to be here. This is Roman Romero Tuno. First of all, to congratulate all the speakers, colleagues for supporting this very interesting webinar, and also everyone really who's attended with a large volume of interest people. So just really kind of delighted to be here. Just thank you, Roger, and the Institute of Public Health for hosting the webinar. It's really good to see academic colleagues from many different jurisdictions and also age and opportunity represented really well. And of course, the Northern Ireland Frailty Network really showing again a big interest in this area. So my main area of interest is also frailty and resilience, and I suppose you see the most relevant background is my position as co-lead of the Frailty and Resilience Interest Group of the Irish Gerontological Society, promoting that idea of an Irish Frailty Network, and we've been collaborating with the Northern Ireland Frailty Network and other agencies for a good few years. So I'm really delighted to be here and supporting this.
Brilliant. Thank you. And George, over to you. Just a few words about who you are.
Yeah, morning, everyone. George Bell. I mean, I'm an octogenarian. I went into phased retirement about 15 years ago, and I'm still working. I work for 5 universities. But I'm also interested in trying to have my own lived experience. I don't like the word volunteer, but I see myself as a participant constructor in my own life experience. Why would I not want to be involved in trying to make my lived experience more customized to myself? So that's where I'm coming from. I'm very interested in some of the presentations and questions. I'd be happy to try and bring some of my sort of thinking to those.
Brilliant. Okay, well, look, thank you. So let's kick off. So the first we've got, so I'll just say again, if anybody has a question, please put it into the Q&A. There's specific questions in the Q&A for John and Maria and Alison, but I'll just ask Roman and Ruth, Leila, George, is there anything that stands out from you from the 3 presentations? Anything that strikes a chord? Anything that maybe surprised you? Or so any thoughts? So I'll start with Roman. What stood out for you in any of the 3 presentations?
Thank you, Roger. And for me, really, it's all very impressive, and I think really it's all very complementary at the same time. Look, exercise for older people, but the label of older people really is applied to sometimes people over the age of 60 or 65, but actually evidence of aging in all humans really starts from the 4th decade, even before. I think something that really stayed with me from Professor Fiatarone is that kind of life course approach. So the kind of prevention, from as early as possible. Also as well, a second highlight for me was that heterogeneity in aging. When Dr. Travers was talking about that fitness to frailty spectrum and how really the biological age could be very different from chronological age, and that exercise being one of the components of that healthy aging could actually be beneficial to put us on the more resilient side of the spectrum. So I really took that point away too. And also as well, hearing, the efforts from the Northern Ireland Frailty Network in terms of the lived experience. For me, the third really important aspect is the motivation and also the behavioral change. So really overcoming barriers to exercise, really motivating, enhancing that self-efficacy, confidence, maybe setting goals that are individualized, and anecdotal experiences are really meaningful. I mean, we heard extremely really narrative examples of how even a modest amount of exercise has led to increased psychological and brain health well-being, and then people can build up from there. And so the importance of social supports and the reinforcement strategies with personalized goal settings. I think that behavioral change piece is really, really important. So for me, those are the three highlights of today. I think all the speakers have resonated with that, I think.
Thank you. Thank you. George, I see your hand up.
Yeah. No, I've just trying to build on some context. I'm very interested in high intensity training, and I want to come on to a couple of issues on that. I've been struggling with trying to see if we can actually start to look at care needs in terms of the Maslowian pyramid, because what I picked up from a lot of what people were saying was that do we have to have the sort of layers of needs in place before we can actually get to the higher point of that pyramid where people take ownership of their own training and activities? So probably we need to think about, do we have the physical needs, the safety needs, the society needs, the esteem needs, and then moving on, give people the ownership of their own life, if you like. So we as people involved, or maybe should lay the platforms that we can then give people to have their own life, because there is a tendency that you could actually maybe be making people too dependent. So how do we actually get them to move and take ownership? Now, just moving away from that a bit, I thought high intensity training, wow, that's fantastic. But how can we actually make it work? And I noticed some of the questions in the chat were looking, do we need a personal trainer? And what struck me about Maria's presentation, that we might, could we use artificial intelligence? Could we have a chat bot that would actually be like a personal trainer? Or is this growth in smartwatches actually, is that actually what it's doing? So those are the sort of things I'm trying to think about. If we're going to have high intensity training, it needs to be supervised. And so can we actually use artificial intelligence to actually have that supervision and to make it work so that we don't have people who are actually injuring themselves trying to do too much?
Okay, Maria's still here. Thank you so much, Maria, for staying on board. Do you want to, because that's kind of come up a little bit in some of the chat, and I'm delighted that you were able to stay on. There were questions around, does the high intensity in the weightlifting need to be supervised? Not all people like lifting weights. Is there an alternative to weightlifting that will get you the same types of results? Do you want to share a thought on that, Maria?
Yeah, I mean, I think muscle is muscle, and it doesn't change between the ages of 2 and 100. And basically exposing muscle to an uncustomary load is the original description of weightlifting by DeLorme in 1945. That has not changed. So unless you go to outer space and come back, gravity is not an uncustomary force, unfortunately. So the only way that you can overcome muscle without weights is by using a relatively small muscle to lift your body weight. So push-ups are always pretty hard because it's a tiny muscle lifting a big weight. So that is one sort of exercise that you can use with body weight, but it's pretty hard to overcome. Once you can stand up from a chair with your body weight, unless you gain weight, that's not going to be an uncustomary force. So in my experience, although you can get some benefits, if the actual issue is sarcopenia, there is only one antidote. So sarcopenia isn't the cause of all frailty. So there are people who are frail because of depression, because of polypharmacy, because of isolation, because of poor vision, because of malnutrition. So for those people, there are all those other things that you need to do for frailty. But if somebody's core problem is sarcopenia, the antidote is high intensity weightlifting. So, to do that, you have to be a little creative if you don't have any equipment to do that. And it's not easy to overload the legs in people who have knee arthritis by having them do squats and lunges, for example, which is what people try and do. And what I see personal trainers trying to do in gyms all the time. So, I mean, you're better off, I think, finding one place you can go once a week to do high intensity weightlifting. And that's probably going to get you most of the benefit you need. You know, you don't need to do it more than 2 days a week. But you need to do something if sarcopenia is your core issue. So it's not everybody's core issue, but it's certainly common.
Okay, so that's been brilliant. That's actually addressed quite a few of the questions that have been in the chat, Maria. That's really good. That's given a good bit of clarity. So, Ruth, do you want to reflect on any observations that stood out briefly in terms of the presentations? You know, what rung a chord for you?
But I loved the presentations. First of all, I thought they were, I mean, they're speaking the language that we all want to hear. They're all saying, yeah, you can do it. We can reverse frailty. Exercise is effective. Exercise is important. The nutritional protein count as well is really important as well. I think we all, you know, we know that this is out there, you know, we know that this is really important. Maria's presentation kind of blew me out of the water, all right. I have to say 70% or 80% of 1 rep max wasn't what I was expecting, and I probably wouldn't have considered that myself. So it's really refreshing to see that we can push this an awful lot more. And I would have always been on the idea of resistance training, absolutely. Probably not at 70% of 1 rep max, but I'm going to change things now. But I think it is really essential. But the thing that it's a little bit like what Roman was saying. It's about that. The piece that I'm finding very interesting with the work that I'm doing is the motivation bit, and to really explore why people want to do exercise. I'm doing a lovely piece of work with a student of mine at the moment, and we're exploring intrinsic and extrinsic motivation, and we're finding that there's differences between the sexes. We're finding that the men seem to just don't really mind not exercising on their own, whereas the women really embrace company and they love that social piece with exercise. And it's really beginning to me, it's really beginning to kind of reflect to me that we've got to meet the person where they're at. It's not that we know what's right for them, it's that they know what they enjoy. And if we're looking for behavior change and long-term behavior change, we really have to be led by them, and we go in and we support them, and we can adapt and we can change things for them to make sure that it's becoming habitual and meaningful. And there were some lovely quotes, weren't there? I thought one quote that was really lovely as well, I'm terribly sorry, but the presentation that was from the Northern Ireland, it was that the family started joining in on the exercises. Those kind of pieces they're fabulous. So make it embrace it and enjoy it. And that piece that you needed support maybe at the start, but then it became very meaningful and it became part of your life, and you can keep on bringing it into your lifestyle. I think that's really a piece that we need to work very carefully with and really explore a lot more.
Okay, so, thank you, Ruth. I really appreciate that. And when you think about physical activity, it's about getting something that works for you. I was, Maria, on that point about 1 or 2 times a week. That seems manageable. That most certainly. So that's a good positive message. Leila, what stood out for you from the presentations, or any reflections you've had on what you've heard this morning?
Well, I'm blown over by the whole lot. I think the presentations were brilliant, and it was a great education to me, as I am interested in doing the exercise with older people. Now, they mightn't be as old as me, but anyway. I'll have to change, as Ruth said, I'll have to put more stress on building up your strength and your resilience. I'd be more into the aerobic exercises and the chair exercises, the movement, but I'll have to improve what I'm doing. And I've learned that. I've learned a tremendous amount. And thank you all so much. And I'm so proud and privileged to be on this webinar. And thank you.
Thank you. Thank you so much. Those words are very kind. So, guys.
Can I just say one thing?
Yes, go on, Maria.
So I think people are very afraid of this 1 repetition max idea. But if you think about it, if you're trying to get up from a chair and you don't use your arms and you're just trying to use your legs to do it and you fail, and so you have to use your arms, you've just done a 1RM, right? You've just failed your 1 repetition maximum because your legs aren't strong enough to lift your body weight out of a chair. And so you have to add your arms. So people do this all day long. 1RMs are not scary. It's what people are doing all day long. So the idea that you need to be at a low intensity to be safe is just completely non-evidence-based. And although I know, it's about behavior and getting people to change their behavior, the way I'm a geriatrician, I'm not an exercise physiologist. So exercise is medicine for me. So if I have a drug that somebody I know needs to take for a particular they have, and I know that it works at 100 milligrams and not 20 milligrams, it would be crazy for me to give them 20 milligrams because they need 100 milligrams. So exercise is exactly like that. And I feel like if I am treating sarcopenia with ineffective exercise, I'm not being a good doctor. I'm doing them a disservice because we have 50 years of evidence that we know how to treat sarcopenia, but we're not doing it. We're constantly skirting around the issue and trying to figure out some other way to do it without using any weights, without using any equipment, without having any supervision. And we're not treating the sarcopenia. People are dying of sarcopenia. So I feel like we are completely missing the boat in this area, actually.
That's a very strong message. It's the time you're giving the message we need. We need to have the hard conversation that this is important. So how do you start that conversation? And so, John, in your role as a GP, you see a lot of people. How do you start that conversation with someone, that they need to do weightlifting or they need to do more exercise? How do you start? What works? Because there are 1,000 people registered for this event today, and they want to know what works.
Thanks, Roger. Yeah, a series of open questions. I often start with a kind of an innocuous question. Are you getting any exercise in these days? And the answer inevitably is, oh, well, I'm getting my walks in, and walking is high on people's priority list. And so then I start with that and I build on it. And I just introduce the idea of resistance-based exercises using weights. And I talk a little bit about, in very simple terms, research that has been done to demonstrate that weight-based exercises can build resilience and reduce frailty. I do use the language of resilience much more than the language of frailty for the obvious reasons around frailty having those negative connotations. So I lead with resilience. I lead with the concept of creating independence, of increasing functionality. That's not the word I use, but the ability to do simple daily tasks like walk to the shops and carry groceries home, like walk the kilometre through the airport to be able to get an airplane and visit your friends and family. So I talk about the opportunity that's available and using the positive language of resilience. And what I find is that people are really engaged, and there's a huge demand for anything that can help reverse what they felt was irreversible, that can stave off what they thought was inevitable. And there's a sort of an enlightenment that happens in the conversation. People go out, really enthusiastic about this opportunity to do something about what they feared. And then the last point I'll make, which addresses a little bit about the motivation we were talking about, is that we did other studies that showed that a single check-in telephone call from a GP about a month after somebody was left that initial conversation with an exercise sheet, a single check-in informal conversation from the healthcare professional, be it a GP or a nurse, just saying, Mrs. Brown, how are you getting on with those exercises? That increased adherence by about 20%. So there was a big step change in people's engagement with the simple investment from a trusted healthcare professional. So that motivation can be shepherded along, if you like, by people showing an interest.
Okay. Thank you very much, John. That's really helpful. Ruth, the same type of question to you in terms of, your tip for starting that conversation. So now we recognize the importance of, weights, not just walking.
Yeah.
How do you start that? Because there's perceptions around weights, and who does weights, because that's what was really brilliant about those pictures that were showing. That's challenges our perception. So Ruth, what do you think?
Yeah, I agree with you completely there, Roger, as well, and they all love a walk. You know, I completely hear you, John. They're all walking. But I think I suppose that they come to physiotherapy an awful lot, because they know that they want to do exercise, and they know that that it's a good thing to do. And introducing the resistance training isn't that challenging, because they're in that situation with us anyway, Roger. They're coming in to do exercise. So, it's part and parcel of it. So that resistance training isn't that difficult to put it in. Now, we use TheraBands, and we use probably things like John was saying as well, probably the stuff that you would have at home, some heavy equipment at home you would have, or you'd use the gym setting. There is a huge call for there's a big demand for it. People want to exercise safely. They're very anxious about joining. This is the information that I seem to be getting. They're anxious about just walking into a leisure centre and how do they find the class that matches what they're able to do. So I think there's that piece that's quite difficult for them as well, to move on to some other class. But certainly whatever we ask them to do, certainly in the classes that we're doing at the moment, the resistance training is absolutely fine. But we also involve them. A part of the work that we do, Roger, is getting them down on the floor, and that they learn how to cope with the fall and getting back up from the floor. And they find that's a little bit more challenging to do.
Yeah.
That's the challenging piece.
I was going to say, there was actually at the HAPA conference recently, there was a speaker talking about the issue about the difference between successful and unsuccessful fall programs. Those that actually have a muscle strengthening part, because if they're on the floor and they don't have the muscle strength to get up, they will remain on the floor. So that, in many ways, it's an important message in reinforcing what's being talked about. It's a question now for George and probably Alison as well. If you think about the messaging around frailty, it's often focused on older people. Should we be getting this message much earlier into the life course about retaining your muscle, balance, and so on, rather than in later life? I'll go to Roman after George, and Leila has a thought. George, what do you think? If you look back.
I think we need to maybe step back a bit and look at, do we need a culture change? I mean, half my family live in Australia, and so I was interested to see the Australian concept of keeping fit. And I'm thinking, are there culture difference between Australia and Ireland, but in terms of the older folk? So we don't really know that. And I've worked in China, and I've seen older people meeting in a park in the morning doing Tai Chi. And I've never been to the States, but I guess the States are also an aging population that are looking at. So I think that, yes, there needs to be maybe an understanding of changing the culture in Ireland, particularly amongst men. And whether or not younger men are completely different than my age group, I hope they are, in terms of their health. But my group really grew up, I would say, in a traditional Irish male sort of hard drinking, whatever attitude. So I think those are also issues that need to be considered, particularly with messaging, and how we would focus on. I think, yes, there is a need to maybe focus on earlier fitness. And one of the things is that a lot of younger people now are suffering from diabetes and stuff like that. So again, it's not that the message would be separate from frailty. It would be connected into a lot of the other health messages. One thing, I actually got a thing from my doctor saying I was in danger of getting diabetes too, which I couldn't think about. I thought, well, why that? Because I see myself as fairly fit. But then we had a session to enlighten people who were in danger. But the paradox was, we had the session in a leisure centre. So there was no connection with the session and then maybe some exercise after it. We had to go away and do our exercise away from that. So there could also be a need for some connectivity between some of the other issues that are involved and a bit of fitness with that. Because you tend, if you go to a session on diabetes, talk about diet, tell you not to eat McDonald's and things like that. But it could be that the next stage could be actually to connect that with some form of physical activity. So connection with some of the activities and bringing in it and maybe in leisure centres would maybe be a good idea.
Thanks, George. So you're talking about life course connected messaging, not just leaving it to your frail, but actually thinking about the range of issues that are really important across the life course. Alison, just briefly, do you want to add anything from your position on messaging?
Yeah, I just totally agree with what George has said. And I think, the opinion survey sort of highlights the fact that in the younger age groups, people aren't really thinking about these things. And I know gyms and protein intake is very sort of buzzword at the moment for a lot of the younger audience, but they're not thinking about that connection as to how they age. It's the here and now. And again, not sort of wanting to bang on about my own parents too much, but they were both brought into the GP and told they were pre-diabetic, in their 70s. They went off, changed their lifestyle, lost weight, started to move more. They're healthier now than they ever were. But, those messages didn't occur to them in their, 50s, 60s. They weren't thinking about these things. They were living life and, none of that was getting through. So yes, absolutely. It is messaging for all ages.
Yeah, so that life course messaging cross-sectoral, showing the practical parts of what you can actually do, what's possible. Before I go to Roman, Leila, there's a message in the chat that says there should be one of you in every part of Ireland, which so I thought that's really great. Do you have what's your thoughts on getting people active across the life course? Have you anything?
What's my thought on that? Well, I don't know how it is that I've just been asked to. I did the PALS course, which was brilliant. I've done it 3 times. I did it when I retired 17 years ago, and I did a Care PALS course, and recently I've done another PALS course, and they were all brilliant. And as I saw a statement there, everyone should do a PALS course. It's great, brilliant. And what was the question you asked me?
No, I think you've answered it. You really have answered that there, Leila. There's something there about, taking action. That's what you're saying. That's about taking action and doing either individually, but it seems to be that the PALS course is a group activity. So that's really important. Yes. Really important. I'm going to go to Roman.
Thank you.
Roman, and thank you, Leila. Roman.
Well, thank you so much. Really, really interesting, stimulating thoughts. I suppose just really to emphasize some principles. One is that, of course, getting fit is a process. You can't really achieve that too soon. Sometimes, it really takes a little time. And that kind of gradual, adaptation to the exercise could be an important principle. The other aspect is that this personalization of the exercise interventions really is very important, because I think it's been mentioned that some people live with specific medical conditions, perhaps have specific situations. And of course, you see that exercise prescription has to be really well personalized. And it can take a while. It can take a few weeks or even months, to acquire those ideal capabilities that sometimes we hear about in terms of resistant training. That we heard an awful lot of resistant training, and in fact, it is a good emphasis. Also, we hear about aerobic exercise, and if you've been very inactive, or perhaps you've gone through a period of illness or disability, and you are at a very low point, then you should really kind of try to bring that very gradually and slowly build up that activity in the exercise dose to meet targets. But it can take a while, and of course, a lot of the comments on the chat also refers to the reassurance, and also Ruth mentioned to how reassuring it is for older people who start exercise programs to have supervision and expert advice around them to personalize that prescription. Also glad that the Tai Chi has been mentioned as an example of balance training, because as well as resistance and aerobic, you've got the balance as well. And Tai Chi has been shown benefits for falls prevention. Of course, might require supervision as well, especially in the initial steps. So there's many options questions. And actually, a little bit of everything might be the ideal combination. But of course, you have to personalize to your own personal circumstances, because I totally agree with Ruth. That's the only key to maintaining that motivation and engagement to prevent frailty eventually. So, but I think really it's been very, very stimulating. I'll pass it over to you again, Roger, and thanks everyone for attending.
All right, and thank you all. So look, we went over a few minutes. I thought we would finish at 12 noon, but I wanted to get everybody the chance to take part. To the presentations have been excellent. So I want to thank you all for your presentations, all the panelists for giving up the time. It's been a really brilliant conversation. The recordings will be available after this. The presentations will be available, and John's going to share the resource, the leaflet that'll be part of the documentation we'll share. I want to thank the speakers, the panelists, all the participants who registered, the comms team that made this all look so nice and easy, but that doesn't come so easily. Thanks also to Leah for promoting this, and Toby, who has been working in the background, refining all the questions down. So just as well as Thomas, thank you for your energizer. It was brilliant. We really appreciate that. And finally, I want to say, I hope you have a great day. Just remember, the message in today is all journeys start with the first step. So if the first step is to think about weights, that's your first step, starting, asking for advice. Roman talked about the personalized medicine, the individual. What is it that is required for you in your position, and what will work? Ask the experts. They're in your community, they're in your hospitals, they're in your leisure centres. Ask those for advice. So thank you all. Take care and all the best for the rest of the day. And thank you all for registering. Thank you.